I would like to start our presentation on neuromyelitis optica spectrum disorders and provide you with an update regarding this condition. So the first topics that we are going to look at is from Devex disease to neuromyelitis optica. Before we do that, I would like to provide you with some disclaimers. This is a program for informational purposes. This doesn't replace medical advice by a physician or a healthcare provider. As always, the content of this information provided over here is thought to be correct as of the time and this program was recorded. The opinions expressed are those of the author and the presenter, and where copyrighted material is used that others have put together, this is done so under the fair use provisions. From time to time, you also see this little soapbox on the bottom. The soapbox indicates that I will express my opinion, which may be in part a little bit different from perhaps the Academy of Neurology or societies. But nevertheless, I do think that this is important for you to also understand what the rationales are, what the opinions are in this area. So as I mentioned, this first chapter is from Devex disease to NMOSD, to neuromyelitis optica spectrum disorder. And as I will go through this talk, you will see that this is a little bit differently organized from the prior talks in this 3-talk series that we put together. This particular presentation will highlight different aspects, and I hope that as you listen to it and as you walk away from it tonight, you will see certain facets that may be of interest to you. The first thing is to get a little bit of a glimpse how research works and how research is in the end bringing new solutions, bringing new ideas to a field where before we were in a way stuck, or where things were not completely evident. The other thing is also to show you that a condition, so that at one point in time may have been viewed as part of another condition, through research, through new understanding, becomes its own disease state, to then only experience further investigation and further subdivision into yet other disease states. What I just said will become hopefully clearer as I go along in my presentation. The third point, I think, is also to show you how once we understand mechanism of injury, once we understand how something happens, this really gives us an opportunity to start looking at how we could treat this. This is a really research-based approach, an understanding of the disease. And then this understanding of the disease will ultimately help us to arriving at medications that can control this disease state, can treat this disease state. So let's go back about 150 years. Around that time, there was the first description of what we call neuromyelitis optica at the time. This was called a disease that affects both the eye and the spinal cord. And in 1894, it was De Wicks, through graduate students of his, that for the first time used the term neuromyelitis optica, because he described a patient that had inflammation in the spinal cord and had optic neuritis, inflammation affecting the optic nerve, the part of the brain that serves vision, serves the eye, that had both of these conditions. And so the term neuromyelitis optica was coined at that point in time. So then we go for almost about 110, 115 years, where neuromyelitis optica was considered a form of multiple sclerosis, a more aggressive form of multiple sclerosis, but nevertheless as belonging into the group of diseases that make up multiple sclerosis. This has changed with understanding that has accumulated over the last about 25 to 30 years. It's now clear that neuromyelitis optica and neuromyelitis optica spectrum disorders are their own category of conditions. And I will, as we go along, hopefully to your satisfaction, explain how we come from NMO, neuromyelitis optica, to NMOSD, neuromyelitis optica spectrum disorder. So what changed the world after about 110 years of looking at neuromyelitis optica as part of multiple sclerosis? Researchers at the Mayo Clinic and others too were looking at lesions, were looking at pathology specimens from NMO patients. And what they could see is that in the lesions of NMO, there were certain proteins that were deposited in the areas of the tissue injury that could be observed. And so that was the first time that one saw that probably a certain kind of pathology was ongoing, namely that perhaps in neuromyelitis optica, an antibody-based pathology was very important. It took then the researchers at the Mayo Clinic only a relatively short time to recognize what this antibody was and what it recognized in these areas of neuromyelitis optica lesions. And what they were seeing is that patients with neuromyelitis optica, many of the patients with neuromyelitis optica, had an antibody that was directed against something on the surface of cells within the brain. And the cells that contained this are very specific cells. They are astrocytes. Think of astrocytes in a way as the logistics. They are almost in a way the Amazon of the central nervous system, because what they do is they bring nutrients from the blood vessels to the nerve cells and also help get rid of stuff that accumulates in the brain. So recognizing that the surface feature on these cells that are so important was a very important thing to do. The second thing is, what became clear is that this protein that is featured on the astrocytes was a water channel, the aquaporin 4. Aqua for water, porin for whole. So it's a water channel. Think about it in the brain. Tissue doesn't just allow water to pass through it nilly-willy. Otherwise, potentially, there would be a lot of swelling. Water transport in the brain is relatively tightly controlled. And it is the astrocytes that control this. And you see here a cartoon of an astrocyte that expresses these water channels, the aquaporin 4, and essentially hugs the blood vessel, the small blood vessel that brings new nutrients into a certain area. And if we then see how this is in the brain, you see here the astrocyte that hugs the blood vessel, reaches out to the nerve cells to give them sustenance, and then also takes away from debris and used spent waste materials, takes them away from the nerve cells. So you see over here that this aquaporin 4 is actually very important in maintaining health within the tissue, and aquaporin 4 is expressed in certain very specific areas of the central nervous system. So in many patients with NMO, one could find this anti-aquaporin 4 antibody. And so many of you that have neuromyelitis optica or have been tested for it have this AQP4 antibody, or another name that is sometimes used, the NMO-IgG antibody. And so you now know that this is directed against the surface feature on certain cells in the brain, the astrocytes. As I will much later in the discussion also show you, there are other parts of the body where aquaporin 4 is expressed. And that's then also where it's important when we think about risks or other conditions that could be occurring in a patient with neuromyelitis optica spectrum disorder. So where is aquaporin 4 expressed in the brain? It's expressed at the surface of the brain, and it's expressed in different parts along the fluid-filled areas within the central nervous system. Fluid-filled areas are the ventricles. And so if you think about that, we can then start to think, well, in neuromyelitis optica, there are lesions, there are areas of damage that occur. Where do they occur in the central nervous system? And interestingly, these areas of injury in the central nervous system are significantly where aquaporin 4 is heavily expressed. And you see this over here in this cartoon, where we see on top the two eyeballs, and behind the eyeballs we see the optic nerves, and where the two optic nerves come together, that's the chiasm. So you see that in neuromyelitis optica we have inflammation in the optic nerves. You see the spinal cord, again an area where there is a lot of expression of the aquaporin 4. And then on the bottom you see these areas around the ventricles where aquaporin 4 is also significantly expressed. And now, as we go through the conversation tonight, you will see that each one of these areas can lead to a specific clinical manifestation. Sometimes a person can have more than one of these areas involved, and that's why we have neuromyelitis. Myelitis stands for the Greek myelon. You see this in the spinal cord. Optica, and optica refers to the optic nerve. So you have patients that have involvement of the eyes and the spinal cord. But you also have patients that have involvement of these other areas, and hence the term neuromyelitis optica spectrum disorder. And I think this is important to keep in mind, because different patients that are diagnosed with neuromyelitis optica may have come to this diagnosis with different clinical manifestations. Somebody may have come to the diagnosis of NMOSD through having optic neuritis or involvement in the spinal cord. Somebody else may have come to the diagnosis of NMOSD through the fact that they had uncontrollable hiccups for a period of time. What many of these individuals have in common is the fact that they have an antibody, the anti-aquaporin 4 antibody, the anti-AQP4 antibody, which is a common feature. And so I have given you the first explanation why we moved from the term NMO to NMOSD, because with NMOSD we have more conditions that are comprised under this terminology. And we then think about how does NMO differ from multiple sclerosis, the condition where it was for many, many years, for more than 100 years, looked at as being part of. And you see this over here in multiple sclerosis. Involvement, optic neuritis is often unilateral, and it is not bilateral as in NMOSD. In the spinal cord, the lesions that are observed are often small and lead to more discrete injury. And when we look at the brain MRI, in neuromyelitis optica, the brain MRI is often normal, where in multiple sclerosis, we see the MS lesions, or sometimes also referred to as the MS plaques. So there are important differences between these individual groups of patients, but these things only came to kind of full recognition once we had the neuromyelitis optica antibody, the aquaporin 4 antibody, recognized. So does this really matter, what I just said? Well, if we look in patients, and if you look on the MRI in patients, and wherever you see the darkness in these images on top, like for example here, that's a ventricle, that is a ventricle, and you see that the lesions or the areas that are abnormal in neuromyelitis optica are around these areas. They are all in the areas where the aquaporin 4 is heavily expressed. For example, you see it over here in this area that is close to the cerebellum. So with the neuromyelitis optica antibody, we have a biomarker. We have a biomarker that identifies the disease. We don't have such a laboratory-based biomarker for MS. If you view the prior discussions in this series, you will see that we in multiple sclerosis, we always talk of the MRI as a biomarker. Here in neuromyelitis optica, we have now a biomarker that actually defines the disease. So we have a diagnostic biomarker. But just keep in mind that there are other biomarkers that we would like to have. We would like to have a biomarker, for example, that tells us whether somebody is at risk for a disease. We would like to have biomarkers that tell us whether somebody responds to treatment. So that's a monitoring biomarker. We would like to have a biomarker that tells us where somebody is going to go in terms of whether the disease is going to be aggressive or less aggressive. And obviously, particularly when we have treatments, we would also potentially like to have a biomarker that tells us whether something is safe or not safe, or whether the patient is at risk, or whether everything is fine. And so when we think of the aquaporin 4 biomarker, this is a diagnostic biomarker. It helps us diagnose NMO spectrum disorder. Not in all cases, but it certainly helps us to do. It may have also a prognostic value, because as we're going to discuss later on, all the currently approved treatments for NMO spectrum disorder are approved for patients that are positive for the anti-aquaporin 4 antibody, because in the individuals that are negative for the aquaporin 4 antibody but are believed to have neuromyelitis optica, conclusive evidence regarding the efficacy of these medications is not available at this point in time. So keep in mind that we are now really in neuromyelitis optica spectrum disorder in a different situation from MS. Through research, through the observations that were done and recognized the aquaporin 4 antibody, we have now a diagnostic laboratory-based test where we can identify in many of the patients with this disorder whether they have the disorder or they don't. Whenever we do something like a test, it becomes very important to also now know how the test is done. And in neuromyelitis optica, if we want to do the test, and I will show this to you later on for the diagnostic criteria, it becomes very important that the test is done with the most reliable technology that is currently available. In the case of neuromyelitis optica antibody, IgG antibody, or anti-aquaporin 4 antibody, this is a cell-based assay. And so as a patient, for example, it is not unreasonable to know that your laboratory test has been done with these newer type of techniques. This is particularly important for individuals that perhaps were diagnosed with neuromyelitis optica in 2003, 2004, or before that, when the tests that we had were not yet fully developed. What you see on the right-hand panel over here in the box is the fact that even if we have these new, very reliable tests, not every patient that we think has clinically neuromyelitis optica tests positive for the neuromyelitis optica antibody. So keep that in mind. There is a second important point here on the slide, and that is the fact that none of the MS patients that was in this sample or was tested here was positive for this NMO IgG antibody for this anti-AQP4 antibody. So the anti-aquaporin 4 antibody is really specific for neuromyelitis optica. So what I would like you to take away here is the fact, yes, we can test it. Yes, the test has evolved over the years. Yes, there are good tests for NMO antibody. But yes, not every person with NMO is gonna have the anti-aquaporin 4 antibody. And that goes towards the point that I made early on in our conversation tonight. Remember, I said for 100 years, NMO was viewed as a part of MS. After 100 years, we have taken NMO away from MS and have said this is its own condition. As we have developed the anti-aquaporin 4 antibody, it became also clear that some of the patients that we view as having neuromyelitis optica spectrum disorder don't have this antibody. And so it raises then the issue, is that a technical defect that we don't detect these antibodies because either the patients didn't produce it, or is the test not sensitive enough, or do these individuals have a different condition so that even NMO spectrum disorder is made up out of different conditions. So it's almost like the Matryoshka doll, right? You had MS, you opened it up, here was NMO, you take it away. Now you have NMO, you open it up and you see that there are other conditions included in this. And so, as I mentioned, about 10 to 40% of patients with NMO spectrum disorder don't have the anti-aquaporin 4. So we have the patients that are aquaporin 4 positive. And we have this subgroup of patients that are anti-aquaporin 4 negative. Looking at the patients that are aquaporin 4 positive, so they have an antibody against the foot processes of the astrocytes, the water channel, the aquaporin 4. In the individuals that were anti-aquaporin 4 negative, one found that a significant group of these 10 to 40% of patients had an other antibody, the anti-MOG antibody, the anti-myelin oligodendrocyte antibody. And I'm sure that tonight we have some individuals on the calls that have been diagnosed with anti-MOG disease. And so now you see that there is obviously sometimes when we discover something, the world doesn't become much simpler. It actually opens yet another door to recognize an additional condition. And this is the anti-MOG antibody disease that is contained herein. And obviously, in the middle is the group of people that are undecided. They neither have anti-aquaporin 4 or anti-MOG antibodies, and we don't yet know exactly whether there are other antibodies. But as we set out on this journey tonight, I put to you that I'm going to talk a little bit about research, how research affects how we look at the disease, and how research and discovery then ultimately also helps us to drive towards new understanding and ultimately to treatment for these conditions. And you see over here that out of the observation of the aquaporin 4, we are now at a different stage. And think about it, the aquaporin 4 antibody was discovered or reported in 2004. We are now 16 or 17 years later, And so over the last half a generation, much of our understanding in this condition has exploded and has become much bigger. And we have discovered additional conditions that before we were unaware of. In a certain way, this is also my thinking for multiple sclerosis. I personally think that multiple sclerosis is a spectrum of conditions, but we haven't yet found out how to take it apart. And that's why we have individuals that respond very well, and perhaps individuals that don't respond that well to our treatment approaches. Maybe I'm right, maybe I'm wrong, but at least this is what was informed my thinking about these conditions, that there is yet more to be learned, and we need to, when we learn something, it will help us further in our understanding. So, as I mentioned, with the discovery of the aquaporin 4 antibody, with the discovery that there are people that are negative, we have now a third companion over here. We have the MOG IgG or MOG antibody disease. And in a way, the MOG antibody disease is something that is kind of in the middle between the MS in the presentation and the neuromyelitis optica. It shares features of both of these conditions. As I will discuss with you, MOG antibody disease is more frequent in children than in adults, but nevertheless, it can also occur in adults. It often presents as optic neuritis, but it can also present as transverse myelitis or other syndromes. So, just to be clear, when we have a patient where we entertain the diagnosis of NMO spectrum disorder, there is a group of patients that are aquaporin 4 antibody positive. And because the aquaporin 4 antibody binds to astrocytes, the cells that I call the Amazons of the central nervous system, we call this an astrocyte patopathy, a disease that affects the astrocytes. We have also learned that there are cells that affect that, or there are individuals that have antibodies to myelin oligodendrocyte glycoprotein. And so, as you hear in this word, oligodendrocytes are the cells in the central nervous system that make the myelin that enwraps the nerve cells within the central nervous system. And then we have the individuals that are double negative. And so the two big features here, a disease against the astrocytes and the disease against the oligodendrocytes, are both enclosed in the group of patients that have neuromyelitis optica. So who gets neuromyelitis optica? Neuromyelitis optica spectrum disease is really a global disease. It affects all races. And you see over here in a group of individuals that a survey among many centers showed that both in whites, in Caucasians, and in Black Americans, cases are observed, and that the rate of women is somewhere about 9 out of 10 of the individuals with neuromyelitis optica are women. If you look at the prevalence in the population, it is a little bit more prevalent in Blacks than Asians, than whites. So you see the distribution over here. So this is really a disease or a condition that occurs around the globe, in many different populations. But think about it, a prevalence of, for example, 3 out of 100,000, this is really an orphan disease. This is an infrequent disease, and that's why many practitioners, many people haven't heard about this condition, and that's also an area where then ultimately being a specialist center or being seen at a specialist center becomes very important. Here I show you where it is and the prevalence in different parts. And you really see, I don't want you to look at the individual countries and things like this, but look at it as the globe. Neuromyelitis optica is really a condition that affects everybody. It's not in an area of the globe. It affects individuals of every race, slightly different in the prevalence, but nevertheless, it's present in Asians, it's present in Sub-Saharan Africa, it's present in Caucasians. What's different between the groups? Well, in whites, the onset of neuromyelitis optica spectrum disorder is often in the 40s. In Asians and in blacks, the onset is earlier, about a decade earlier. So there are some age differences between the groups. The other thing that is different over here from MS, for example, in MS, about 1 in 5 patients with multiple sclerosis has a family member that has MS. In neuromyelitis optica, this is only about 3 to 5%. So only about 1 in 30 to 1 perhaps in 20 has a family member with NMOSD. But in the families or in the persons that have neuromyelitis optica, there is often a high rate of other autoimmune conditions. And that's very important because we need to take a history of autoimmune condition or conditions that fall in this group when we evaluate patients with neuromyelitis optica. So if, for example, a father has neuromyelitis optica, what's the likelihood for a child to have neuromyelitis optica? It's very low. If a person in the family has neuromyelitis optica, what's the likelihood of somebody else to have neuromyelitis optica? It's very low. That doesn't mean it's unheard of, but the inheritance is much more complex. On the other hand, if we see autoimmune diseases in neuromyelitis optica, they are a little bit more frequent, both in the persons that has it and also in the family. How is NMO different across different ethnic groups? In whites, very often the area of the brain that coordinates eye movements, what the brainstem, and also the brain is less frequently involved. So whites have more spinal cord involvement compared to Asians and blacks. And severe attacks are a little bit more frequent in black than Asians and Caucasians. In general, an older age of onset is a little bit more concerning because it could lead to earlier disability, which then also puts pressure on us to come relatively quickly to a treatment. And this I will revisit with you when we talk about clinical considerations. What are the most frequent clinical presentations of NMOSD? I already mentioned optic neuritis. The involvement of when the vision goes down, and this can be relatively rapid. The involvement of the spinal cord, where somebody gets weakness or can't walk anymore. This is transverse myelitis. Some individuals also may have intractable nausea, which we refer to the area postrema syndrome, but I will come back to that. And interestingly, there is also a form of neuromyelitis optica that can lead to a narcolepsy-like state or can interfere with cognition, can make a person almost unresponsive. We call this the diencephalic variant of neuromyelitis optica. So over the last 15 years, diagnostic criteria have been put in place, have been developed, and I show you here how they come up, and I also show you some examples from an MRI point of view. So in order to diagnose somebody with neuromyelitis optica in a person that is aquaporin 4 antibody positive, one just needs one of the clinical events or one of the clinical presentations. The first clinical presentation is optic neuritis. Here you see an eyeball, and behind the eyeball you see these optic nerves, and both of these optic nerves are involved. So this is bilateral optic neuritis. Acute myelitis, this is involvement of the spinal cord. In contrast to the involvement of the spinal cord in multiple sclerosis, in neuromyelitis optica, the involvement is often longitudinal, so it spans multiple vertebral body lengths throughout the spine. That's why we often refer to it as longitudinally extensive transverse myelitis. Then we have the area postrema, or the area in the back of the brain, here with the cerebellum. You see the inflammation over here, and some individuals have nothing else but uncontrollable hiccups and also nausea and vomiting. That's obviously potentially dangerous because a person could dehydrate. And then we have individuals with an acute brainstem syndrome. You see it over here, where the inflammation is right on top of the spinal cord. And obviously this can lead to a lot of weakness and a lot of dysfunction with the eyes. And then there are the other syndromes, and the most prominent one here is the diencephalic syndrome. That's the condition where somebody may have a narcolepsy-like presentation and can also have significant cognitive changes or being unresponsive. And so if a person is NMO antibody positive, just having these clinical syndromes is sufficient to diagnose them. When a person is NMO antibody negative, a little bit more workup needs to be done, and additional, beside the fact the cardinal features of neuromyelitis need to be present, certain things also need to be ruled out, and one needs to make sure that the MRI has certain characteristics and also ensure that other conditions are not present. And so this is in individuals that are negative for the antibody. What are conditions that can potentially mimic? Without going into detail, there are many of them. And obviously, sometimes they're clinically self-ruling out because of how a person presents. But it's also very important that one addresses this differential diagnosis in these relatively rare conditions. Think about it. It's only about 1 in 100,000 to 3 in 100,000 patients or individuals that have this condition. What's also very important is once one diagnoses a patient with neuromyelitis optica to think about other autoimmune diseases that could be present in this individual and work them up. Autoimmunities that sometimes go together are lupus and Sjogren's disease. Lupus is the condition where the skin can be involved, the kidneys can be involved, and other conditions need to be ruled out in such individuals. Early on, I discussed with you about this newly diagnosed form of a condition in the NMO antibody negative individuals. This is the MOGAD, the MOG antibody disease. We call this now MOGAD. Maybe we come up with a better name at some point in time. I told you about that in neuromyelitis optica spectrum disorder, the gender ratio is 9 women for 1 man. Here in the MOGAD, it's more 1-to-1. It's also important to know that this is a condition that affects children more than adults, and so it's present. Look at the rate of the annual incidence. In a total population, it's for adults, it's about 1 in a million. For children, it's about 3 in a million per year. So it's a rare disease to see. And again, as we have seen with the neuromyelitis optica, there are areas that are involved with this condition. Most of the individuals with this condition present with unilateral optic neuritis or also present with multiple lesions on their brain MRI, which we call ADEM or acute disseminated encephalomyelitis. So at this point in time, I have a little bit filled your head with many considerations. And I think we are up for a break. So we will reconvene in about 5 minutes, and we will talk about clinical considerations in neuromyelitis optica spectrum disorders. Thank you. So thank you for coming back from the break, and we are going to do some additional considerations in clinical considerations with neuromyelitis optica. So the second part is now clinical considerations of neuromyelitis optica. So how are individuals presenting with neuromyelitis optica? The most frequent presentation is optic neuritis and myelitis. Less people present with the other syndromes that I previously discussed with you, the area in the back of the brain where somebody can get hiccups, or the area in the brain, the diencephalic syndromes that leads to, for somebody to lose consciousness or awareness or have a narcolepsy-like presentation. So looking at what presentations are there over a lifespan of a person, you see over here that essentially this feature early on is mostly optic neuritis and myelitis right at the beginning of the presentation. Bill, I don't think I have the controls. Now I have them. So what's the difference in the course between MS and neuromyelitis optica? And I think this is an important consideration because that also informs you why in neuromyelitis optica we really need to be proactive with treatment, and we can not go through a escalation of treatment approaches as sometimes the insurance companies want us to do in MS. It doesn't make sense in MS. It particularly doesn't make sense in neuromyelitis optica. And if you direct your attention to the lower graph over here, what you are seeing essentially, that worsening of disability occurs with attacks. So in neuromyelitis optica, very often with every attack, there is something left behind, which makes it very necessary to control the disease as early as possible in individuals with disease. This is true for MS and neuromyelitis optica, but it's particularly true for neuromyelitis optica. In contrast to neuromyelitis optica in MS, sometimes we have worsening disability at the time when a patient no longer has a lot of attacks. We call this secondary progressive disease or progressive disease. And so there are clearly distinct manifestations in patients between these two conditions. With neuromyelitis optica, often considered as conditions that can have much more significant impact even with very few relapses in an individual. And so when we look at comparison between MS, attacks in MS can be severe, but they are normally not that severe. In NMO, they can be and usually are severe. Talked about the brain MRIs that has been seen before, and we talked about the sex ratio in individuals. Very important in neuromyelitis optica spectrum disorder is the fact that often comorbid or coexisting autoimmune conditions are present in individuals. We also know that the aquaporin 4, about 2 out of 3 patients are positive for this antibody, 1 out of 3 may not be positive. Obviously, none of the patients with MS have aquaporin 4 antibody. It's almost exclusive. I put this slide in. I don't expect you to be pathologists to look at this, but I think it makes it clear. Look at the light center over here. When neuromyelitis optica occurs, it can really injure the areas. This is the spinal cord over here. And obviously, what I'm showing you over here is spinal cord injury by the disease process of neuromyelitis optica. Not the things that we normally would like to have. When we started out this journey this evening, I talked to you about the fact that I will show you how research affects our understanding of a disease process, and also how our understanding of the disease process then can lead to new discoveries with respect to treatments, and obviously also to discovery of new disease states as we start to take it apart. And I kind of used the model of a Matryoshka doll. Here I'm now showing you how we think of the disease process of neuromyelitis optica. We know that the antibodies, the aquaporin antibodies, are very important. We know that antibodies are produced by cells that we call B cells. These B cells can produce antibodies. And so what you're seeing over here is already 2 potential directions or more than 2 directions for treatment. We have a direction that goes against the cells that make the antibodies. We have directions that prevent the antibodies from doing damage. And we may have a direction that takes the inflammatory environment, the inflammatory juices that exists when such injury occurs, that we could block this pro-inflammatory environment. And that's then what essentially becomes evident when we look at our current treatment approaches. Bill, if you could help me. And you see over here the treatments that are available at this point in time. This is a treatment that goes against the cells that are thought to be involved in the antibody system or the regulation of the antibody system. This is a treatment against the complement, and this is a treatment against the pro-inflammatory environment, this kind of upregulation of the local immune response. Think about it. This journey started in 2004. In 2019, 2020, we have now 3 treatments of different nature for the treatment of neuromyelitis optica spectrum disorder for individuals that are positive for the anti-aquaporin 4 antibody. Think about it, 2004 to 2019, 2020, that's about 15 years. But this progress was made possible because we understood the underlying pathology of the condition. And this allows us now to progress with actual treatment for individuals with neuromyelitis optica. Different, separate mode of actions of how we treat neuromyelitis optica. We have one, as I mentioned, that is directed against the B cells. We have one that is directed against the complement, and we have one that is directed against the pro-inflammatory factors against our interleukin-6 receptor. Which one the right medication is obviously going to be a discussion on an individual basis, but it's also important to note that while we have 3 treatments for patients that are aquaporin positive, for the patients that are aquaporin 4 antibody negative, NMOIgG antibody negative, we don't have approved treatments at this point in time. So we use a lot of the treatments that we previously used, and there may be in the future new treatments that become specifically available for this group of patients. Obviously, it will also be important to know, particularly with the MOG disease, that sometimes is a one-time disease where the patient presents once, who we need to treat and who we don't need to treat with longitudinal medications. This brings us for a second to a discussion regarding how do we get access to medications. And very important here is to understand that what we as physicians can prescribe ultimately depends on the formularies that the patient has access to. And this becomes significantly important in a condition such as neuromyelitis optica, where potentially individuals have been treated with medications that have previously been used but have not been approved for neuromyelitis optica, where obviously the access to medication becomes very important for individuals. And there is something that potentially, and I'm hope that this year will be the year where in the Commonwealth of Pennsylvania this will be introduced. So this is my soapbox in the legislature, that is that individuals with rare diseases such as neuromyelitis optica do not need to try a favorite medication of the insurance company, that they actually can use the medications that the physician, the specialist, thinks is most appropriate, so that we are getting rid of something in neuromyelitis optica or in other rare diseases, which we call step edits, where individuals have to try a favorite medication first and then only can go to the most appropriate treatment for their condition like neuromyelitis optica. So we have 3 treatments approved for NMO IgG positive individuals. We talked about who gets NMO disease. Now let me talk about special groups. The first one is pregnancy with neuromyelitis optica. Normally, when we talk about multiple sclerosis, I tell you MS is not a risk disease for pregnancy. This is a little bit different for neuromyelitis optica. A person or a young woman that is of childbearing age and has neuromyelitis optica really needs to have a planned pregnancy. I'm not saying pregnancy is not possible. The reason for that is that when I early on mentioned to use that aquaporin 4 is expressed in the brain and in other organs, the aquaporin 4 is also expressed in the placenta and in the uterus, and with that can potentially lead to a higher risk of preeclampsia and miscarriages. So a young woman who has neuromyelitis optica and would like to become pregnant, this needs to be a planned pregnancy, and the person should be followed by a high-risk OB. The aquaporin 4 antibodies can go through the placenta, but they don't seem to affect the baby. A small fraction of individuals, of patients with NMOSD are children. As you see here, the number, it's about 1 in 20, 1 in 30. The presentation in children is a little bit different. Very often it presents itself what we call acute disseminated encephalomyelitis, where many lesions occur at the same time in the brain of these children. This is particularly the case in children that are young, so before puberty. In children after puberty, neuromyelitis optica often behaves the same as in adults. Neuromyelitis optica and vaccinations. There is not as much information regarding vaccination safety in neuromyelitis optica as there is in MS. In general, non-live vaccines, like the flu vaccine or the vaccines that I'm just going to talk about, are generally considered on the safer side. A patient with neuromyelitis optica, and this is my opinion, should not get a vaccine during an attack. And a patient with neuromyelitis optica should not get live vaccines unless there are specific considerations, or it's also done under the supervision of a healthcare provider. In general, patients that receive the vaccine should be on a disease-modifying therapy, should be on a treatment for their neuromyelitis optica condition. Everything that I said regarding the vaccines is valid for this. Having said all of this, there are obviously practice questions that are important in neuromyelitis optica. One of the important practice consideration is the issue of how do we integrate, now that we have 3 treatments approved for neuromyelitis optica, how do we integrate what the patient has been on before these treatments were available. It's obviously also important to know that while each one of these agents that is available has proven its efficacy in clinical trials, there hasn't been a head-to-head trial, and I don't foresee that we will have head-to-head trials to evaluate the relative efficacy. And one of the other important things for us to consider is, what do we do with individuals that are double antibody negative? How do we treat them? Obviously, at this point in time, we treat them very much with the medications that have been used in NMOSD for years. What about the COVID vaccine? I just talked to you about vaccines. Well, the COVID vaccine is a non-live vaccine. And since COVID is an active infection, it is at this point in time, my opinion, that patients with neuromyelitis optica that are on treatment should get the COVID vaccine, because the risk of the vaccine is far lower than the potential risk of the infection associated with the condition. And this is obviously also important to keep in mind, that in the majority of individuals, the risk of the vaccine is far lower than the risk of the potential disease. Keep in mind that in the general population, about 1 in 20 people has a significant challenge. This risk goes significantly up in individuals of other conditions. At this point in time, I am, and I'm on the soapbox, a little bit partial to the mRNA vaccines from Pfizer and Moderna. This has more to do with the fact that potential in the future, at one point in time, revaccination may be necessary when new virus strains emerge from other areas. We are currently discussing Brazilian isolate, the South African isolate. Some of these isolates, some of these viral mutants may not be responsive to the currently available vaccines that are there. Again, while not specifically called out neuromyelitis optica, nevertheless, women that are pregnant, unless there are significant contraindications, can be vaccinated with the neuromyelitis optica. Sorry, with the COVID-19 vaccine. We are at the other end of the presentation, and I know that I have challenged you a little bit with a lot of scientific considerations, but I do think that a dialogue such as the one today is important, because it gives you an understanding, or I hope it gives you an understanding, how progress in science is arrived at. But it also gives you an understanding, if you are diagnosed with neuromyelitis optica spectrum disorder today, that when you talk to your friends that perhaps also, or acquaintances that also have neuromyelitis optica, that not everybody coming to the table that currently carries this diagnosis of neuromyelitis optica has the same condition. And so I do think that it's very important to keep in mind that there are underlying differences, and there is much more to be learned about all of this. But as we have seen from the availability through research, through clinical studies of 3 effective treatment for the management of neuromyelitis optica spectrum disorder for patients with aquaporin 4 antibodies, we obviously learn a lot and we progress rapidly towards effective management of these conditions. With that, I'm more than happy to entertain your questions, see whether I can answer them. I see a question over here that asks, how often should one have the neuromyelitis optica antibody test? Again, that depends on when you were first tested. Obviously, all the tests that are currently performed are in general the cell-based assays that I mentioned. They're the high-resolution assays. If a person had a test for neuromyelitis optica, then this can potentially be different if the test was done in 2003, 2008, before the current generation of antibody tests became available. A second question that is over here is if a patient is stable on their current treatment, is there a necessity to switch therapies? Again, this is something that is best discussed with your individual physician. Nevertheless, if a patient is currently stable and the history of relapses is relatively remote, obviously a consideration of leaving this patient on the current treatment is certainly a possibility. We have one more question over here. You mentioned the point that genetic, where other family members have neuromyelitis optica, is rare. Only 3 to 5% of people have this condition, or other family members have condition. If one person has a neuromyelitis optica, does that mean you would not test these other members of the family? That is correct. I would not test the other members of the family unless there is symptomatology in these individuals. We have one more question. Do you recommend flu vaccine in patients with neuromyelitis optica? Flu vaccine is a non-live vaccine. And again, non-live vaccines in general are on the safer side in neuromyelitis optica and are generally viewed as safer in patients that are on some form of treatment for neuromyelitis optica. Again, keep in mind that any of these infections, if they are occurring by themselves, also have significant effects on the underlying condition. Give another minute or two to see whether you have additional questions. If this is not the case, I thank you for attending tonight, and I would again make a shout out for you to understand that many of the programs at an MS Center are supported through the generosity of individuals. This includes training programs, social work, and outreach programs. I would like to again thank our sponsors, particularly the platinum sponsors, Biogen. Your support is instrumental in bringing such information to individuals that are interested and concerned by neuromyelitis optica. And I also would like to make you aware that all 3 programs in this series are going to be online and available for your review at your leisure. You see the website, it's the same one that you used for the live presentation. And finally, I would like to thank you for taking time out of your busy schedules, attend tonight. And I hope that this presentation answered some questions that you have. And I also hope that it raised some interest for you to learn more about your condition, about the condition of a family member or a friend to better understand this, but also gave you a little bit of insight in how advances in a condition such as neuromyelitis optica, and for that matter, how advances in the medical field occur. And with that, I wish you a good night. Thank you.